This presentation is on the topic of recommended but unfunded vaccines and how we can create trust in the patient immunization pathway. Here are my disclosures for this presentation, including speakers' fees, advisory boards, and I am a current employee of the UBC Faculty of Pharmaceutical Sciences and the clinical director of the travel medicine clinic TravelRx Education Incorporated. In terms of commercial support disclosure, I have not received an honorarium for this presentation. This presentation was presented at the Canadian Immunization Conference in 2020. The learning objectives are a bit lengthy, but I want you to focus on the key message of building trust in the patient immunization pathway. And I want to throw a question to the audience in that, what do you think the patient immunization pathway looks like in this country? Is it as easy as we think? Is it daunting? Is it challenging? What are some barriers? What are some challenges? And how can we improve as frontline healthcare providers in making this pathway easier? Let's take an example here of this family, which comprises of many individuals and their dog. But let's focus in on what their immunization experiences will be. And they will be different. Each member of this family will need different vaccines. Each member of this family will receive their vaccines at different locations, with the younger cohorts of the family receiving them probably in public health units, and as we go up into the older members of the family, perhaps at their doctor's office or pharmacy, which leads to them having different immunization providers. So different healthcare professionals, pharmacists, doctors, and nurses will be providing each member of this family immunizations. And then the challenge of records. Each member of this family will have different immunization records, either in different places, and some may have difficulty finding their records at all. And what brings me to my main point of this presentation is that each member of this family will face two categories of immunizations, all of which are recommended, and some they'll get publicly funded, so they won't have to pay for, and some they'll have to pay out of pocket for. So that really is the key thing here, is looking at these recommended or unfunded vaccines, which present a challenge to both patients and healthcare providers in that there's a cost associated with the access to these vaccines. And again, it's across the entire continuum of the family, even before we bring into grandma and grandpa into the picture as well. So the Shifley paper, which was published in 2015, is an excellent expose on the current situation of approved but non-funded vaccines. So it talks about publicly funded vaccines being generally accepted and those that are recommended or unfunded being ignored. And the key word I want to bring into the summary of this paper to the presentation is the word discrimination. So it says here, it's a form of discrimination against vaccines that urgently needs to be corrected. The word discrimination is a very inflammatory term, especially here in 2020. And how are we discriminating against these recommended but unfunded vaccines? Well, the key mechanism of discrimination is not to the public, but actually to the frontline healthcare providers who are recommending and promoting the uptake of all vaccines. So in some of our messaging that we've done for these recommended unfunded vaccines, we've driven this sort of wedge between things that are recommended versus what's going to be covered in the public program. And in my opinion, it has created some confusion for healthcare providers and has certainly left many missed opportunities where frontline providers can recommend all vaccines which can benefit their patients. So I want to start with 3 recommendations, and all of these are for older adults. So the National Advisory Committee on Immunization has 3 individual recommendations targeted to those over the age of 50 or over the age of 65. Looking at influenza vaccines, the high-dose influenza vaccine should be offered over the standard dose for those over the age of 65 for protection against seasonal influenza disease. And in many provinces and territories, this vaccine is not funded as part of the public program. Then there's Prevnar 13, the pneumococcal conjugate vaccine, which is recommended for adults over the age of 65. Again, not funded in most provinces and territories. And then more recently, we look at Shingrix, the recombinant zoster vaccine, which is recommended for adults over the age of 50, which is not funded in most provinces and territories. So all three of these vaccines have specific demographics that we should be recommending them for as frontline providers, but none are available to be covered in the public program. So most of our patients will have to pay for these if we recommend it. Now, what are some challenges and barriers that we see and hesitancies we see from frontline providers in terms of recommending these vaccines? And one of them is sort of cost justification or containment measures that look at why and justify why things aren't covered in a publicly funded program when at the individual level and the patient in front of you would benefit from it. So we look at some of these examples, which again are not meant to undermine healthcare providers, but certainly provide confusion and hesitancy in recommending these vaccines. So we look at Shingrix, which is recommended for adults over the age of 50, and I start with my own province of British Columbia, where there exists a initiative called the Therapeutics Initiative, which looks at independent evaluations of new therapies. So on October 10th of 2018, they provided their first sort of independent review of the Shingrix vaccine. And the results were interesting in that they looked at certain RCTs, so they had their own inclusion criteria, so that's important to highlight, met our inclusion criteria. And if we look at the data, it looks at sort of this absolute versus relative risk reduction. And that becomes a challenge because from a public budget perspective, an absolute reduction really is sort of affected by the low attack rate of these infectious diseases. But at a relative level, if you have the individual patient in front of you, the efficacy of these vaccines in preventing disease are quite considerable. So this study really highlighted the sort of absolute versus relative risk reduction. And I want to highlight a few things in the language. They only looked at the burden of disease over 3.5 years. And we know that with shingles, the burden of disease in terms of attack rates of reactivation of zoster increases with age. So certainly beyond 3.5 years, there is a higher incidence. And also with things like long-lasting complications like posthepatic neuralgia, which can last for years, if not indefinitely. So the wording in this study really kind of certainly biased a lot of healthcare providers in questioning whether they should recommend this vaccine in practice. And it kind of brought up a few things. One was the absolute risk reduction. And the other was saying things like not all PHN is severe or lasts for years. And also saying that most patients, 9 out of 10, would have an adverse effect. So the key message from this TI study was discussing the balance, the baseline herpes zoster risk, the harms, benefits, and costs when considering this vaccine. And the challenge here is, again, not to debate the methods or really get into detail on this, but the key thing here is this is a cost sort of study. And what's happening is it's being extrapolated to individual level recommendations, which again are not affected by this methodology. Again, focusing on British Columbia, so looking at the decision to include the high dose vaccine in the publicly funded program, there's a lot of justification from the BC CDC in terms of why they weren't covering it. Again, looking at the relative risk reduction versus the absolute, looking at the attack rate of the disease in one trial, the pivotal trial of the high-dose vaccine, and kind of generating some numbers in terms of how many would need to be vaccinated and how many would be needed to be vaccinated to prevent one case and hospitalization of influenza. And again, the key thing here is not to debate the results of this analysis, but to ultimately give it some perspective in that publicly funded decisions to include something are very different than individual level recommendations that you as a frontline healthcare provider make. And then going back to NACI, where again, we see this sort of dichotomy now between individual level and public program level recommendations, and NACI puts the conjugate vaccine as an individual recommendation, but also says that it's not beneficial enough due to an economic evaluation to include in the publicly funded program. And again, this is to highlight some of the challenges when we look at cost effectiveness analyses. So in that analysis, if you take a closer look, there is a challenge with missing data in the Canadian Notifiable Disease Surveillance System, as well as the National Micro Lab data sets. So again, we are missing a lot of cases of community-acquired pneumonia. Whether it's vaccine preventable or not, there is a large number of missed sort of underreporting that we see with these diseases. And then we see also another sort of economic evaluation nuance here, where NACI used primary diagnosis of pneumonia in the inclusion criteria and omitted coded secondary diagnoses. So this is a very administrative technicality, which again can miss a lot of cases, causative cases of pneumonia for hospital admission, in that if the patient came in and their primary was pneumonia, then they'd be included, and if they had COPD and then the secondary was pneumonia, they would not be included. So again, that's another sort of data set that is a bit porous in terms of administrative data that was missed in this analysis. And finally, we look at things like age, which NACI only included cases for those aged 65 to 74 years of age, again omitting a large age demographic that is afflicted by pneumococcal disease. So ultimately, this does lead to a lower than actual burden of disease estimate and perhaps skews the decision to publicly fund the vaccine. But again, my point here isn't to criticize these decisions and say that all vaccines should be funded. I do respect budgets, and these considerations are safeguards against sort of funding therapies that may not be cost effective, and we know that money is finite. However, my main criticism is when we look at economic models, the inputs determine outputs. And ultimately, as a frontline provider who's looking at patients right in front of them, it dehumanizes the experience and the recommendation. And it certainly provides doubt in the mind of healthcare providers when cost effectiveness analysis come into play. Now, there are certain areas where lagging behind is not fatal, but remaining there is. So again, lagging behind can certainly be fatal when we look at the vaccine inclusion of vaccines against invasive meningococcal disease in our publicly funded programs, looking at the historical distribution of spikes in incidence of disease, especially in our vulnerable youth and adolescent cohorts. And with each spike, we see the inclusion of a vaccine into the routine program. So in the early 2000s, it was MenC. And every time we do that, we see a decline in the incidence of it because we vaccinated against it. And then we start to see a spike of other strains that are covered in the quadrivalent vaccine. And in 2016, 2017, we saw an outbreak in BC, where in September of 2017, those grade 9 students would be vaccinated in March, not just with MenC, but with MenQuad due to the emergence of that strain. So vaccinating against those strains in the quadrivalent vaccine dropped the incidence of those. However, meningitis B remains perhaps the highest incidence strain of attack rate in the population. Although, keeping in mind the incidence is per 100,000, do we have to wait for an outbreak in order to include these vaccines, and should we stay ahead of it? There are 2 MenB vaccination products available, and both are effective and based on the differential of age, but they are available for protecting patients proactively against this potentially devastating disease. So ultimately, the argument comes down to vaccination and trust, and there's been so much talk in this conference about the trust that is built between patients and the importance of the recommendation from a healthcare provider. Now, these cost effectiveness analysis may be politically driven, economic driven decisions, but as frontline healthcare providers, we have to use our independent judgment and protect our patients as best as possible. So we look at the challenges that we see with sort of controversies and news and challenges that undermine immunization rates, and whether they be side effects to a vaccine and perhaps even psychological in the form of mass psychogenic illness with the HPV vaccine in Colombia, where rates started out very promising and then plummeted. And then same thing in Japan, where they started about 70% and never actually reinstituted the program, leading to a huge wave of impending cases of cervical cancer. And then the other challenge we see is political as well, is when the political side takes decisions and initiatives that undermine the vaccine efforts of healthcare providers. So again, this example taken from 2011, when the CIA used a sham vaccine campaign to identify the hiding place for Osama bin Laden, leading to the massive outcry from many heads of public health across the United States to forbid and prevent the CIA from using vaccine initiatives as covert operations. And ultimately, the fallout of this is politically there was gain in terms of the capture and elimination of Osama bin Laden, but at the same time, the global polio eradication effort took a huge hit because it reinforced that mistrust in the area that the Western world was using that as a way to sterilize or harm the populations in Pakistan and Afghanistan. And then vaccine hesitancy can permeate into general practitioners. So in southern France, the after effect, and this is all the way into this year, has permeated from the 1998 decision to stop the hepatitis B vaccination program. So when there is discrepancies or a lack of congruencies between politicians, health authorities, and frontline practitioners, ultimately it erodes the trust in vaccination and leads to a diminishing level of recommendations of vaccines from frontline providers to their patients. So barriers of vaccination, is cost an actual barrier? Well, according to Canadian physicians, cost was the #1 perceived barrier, and it also limited that recommendation from healthcare providers. So again, going back to the cost effectiveness analysis that constantly get published, sometimes it's difficult to dichotomize that between individual and public recommendations. And NACI has done a good job in separating these, but again, we have to respect the fact that these lines often get blurred, especially when there is a perceived cost barrier for many practitioners from recommending a vaccine, when in reality, the lack of a physician recommendation was actually the biggest barrier, even bigger than cost for most patients. So you can see it's a bit of a negative feedback loop in terms of being a self-fulfilling prophecy where perceived cost leads to lack of a recommendation and ultimately a lack of a vaccine for somebody who can benefit from it. Healthcare providers' recommendation, which has been clearly conveyed in this conference, is extremely powerful and extremely instrumental in improving vaccine uptake. So all this discussion about cost, and if cost is a barrier, who is actually going to pay for it? And that's sort of the question. If you're telling me that as a frontline provider, I should be recommending vaccines regardless of the cost, how do I expect my patients to pay for it? Well, the first thing is giving some perspective. And people will pay for interventions for their health, and vaccines are really no different at this stage. And that's what the Shifley paper highlights. Let's take a look at the HPV vaccine, which is a vaccine which is unique because it prevents a virus that causes cancer. And again, many patients are over the age cohort of catch-up programs. It was recently approved up to the age of 45 years of age for males and females. So the age limits have been increasing for that. And it's certainly a vaccine that's important for taking out a potential cause of cancer. Now, to give patients a perspective, and I've done this in a lot of discussions with patients and B2B presentations, is that what can we do to minimize and mitigate our risk of cancer? So there's many ways we can develop cancer, and one of them is it comes in the form of UV radiation from the sun. So how do we protect against that? Is we wear sunscreen. And sunscreen is interesting because when we look at the effort and the sort of persistence and the lifelong need to wear sunscreen, it certainly gives us perspective on how easy it is to get a HPV vaccination to take one form of cancer out of the equation. But if we're going to go the sunscreen route, let's give it some perspective. Let's show some numbers here. 1 out of 3 patients actually apply sunscreen correctly. Most people actually under-apply it. We apply a lot less than what we need, and we should be applying at least a shot, according to the dermatological associations, a shot glass for each limb, including the face. 3.33%. Even if we do apply enough sunscreen, then there's still a chance that UV radiation will make it through. 40 to 80, that's the amount of minutes. That is the maximum amount. And even if we go with Banana Boat Ultra Sport, which is the sort of the clinically proven to have high endurance for sweat and water, the max we can go is about 80 minutes, and most people have trouble reapplying after that time interval. And finally, 365, that is the number of days in a year that you're exposed to UV radiation. Yeah, even when the sun isn't out, if it's winter time, even if you're sitting in the car, that's how often you should be wearing sunscreen, which I highly doubt that people are wearing it that much and for that long. So to give it some perspective, you can see there are interventions to mitigate risk, and vaccines are one of them, and they're quite effective and straightforward in terms of how they can mitigate risk. The other thing we need to be mindful of, that it's not just about death, but it's also about disability. And this is important, especially in our aging patients, because according to Statistics Canada, the biggest thing that people value is their independence, which again, diseases like influenza and pneumonia are one of the top leading causes of disability. So it's important to note what people actually value is something that they would be willing to invest in or pay out of pocket. To many, their independence is extremely valuable to them, and they will purchase and invest in that by any means necessary. And there are great vaccines for preventing vaccine-preventable disease. So if people aren't going to pay out of pocket, then there's also extended health benefits. Now, again, most health benefits plans typically don't cover vaccines because that means extra sort of premiums for the employer. So it is of the smaller category that we see vaccines being a full benefit. If they are a benefit, some pay and submit, and some bill direct. So again, group extended benefits, are you covered? Having your patients ask the pharmacy for a drug ID number and checking with their benefits plan to see if that's covered. There's also some innovative things that are being worked on in terms of vaccine funding by workplaces. So this is an example through our organization, Immunized.io, with a pilot project we had with the Richmond School District. This was targeting the aging workforce. So again, recognizing the value of those 50 plus who are working in the Richmond School District. There was an educational program that we did on burden of disease for shingles and the vaccination. The HR department surveyed their department, and they found that vaccinations, in particular shingles for those over 50, was extremely valued. So the workplace actually ran a on-site clinic where they reimbursed 50% of the vaccine in the 2-dose series, with our team providing the first dose on site and then patients paying out of pocket. And then the second dose was reimbursed by the district to ensure that 2-dose adherence, and therefore promoting immunization and access to immunization services. So there are unique ways that employers are looking at to cover vaccines for their staff at risk. So ultimately, the lack of public awareness of approved but not funded vaccines is something that certainly needs to change. So we need to recognize that individuals, and this is taken straight from Dr. Shifley's paper, that they have a prerogative to take advantage of a vaccine of potential benefit. The only way they'll ever know about it is if you, as a frontline provider, make that recommendation. In terms of education and promotion, provincial health programs should recommend and promote both funded and private vaccines. So again, both should have the impotence of importance and not focusing on cost effectiveness analysis to defend decisions not to cover it, being fully transparent that these are beneficial vaccines, we recommend it, and not being defensive about not covering it. So ultimately, the challenge is not just with the impending COVID vaccine, because that's going to be a publicly funded vaccine, but the large number of vaccines in the portfolio that we're going to see in the next 10 to 20 years. Will governments be able to fund that? But there always will be patients who will benefit from it, and the only way that they can is if they're recommended by a healthcare provider. So I want to finish my presentation with a little poem about responsibility, and I'm sure many of you have heard this before, and it really kind of sums up the current landscape of not just recommended unfunded vaccines, but vaccines in general. So this is a poem about responsibility. It involves anybody, somebody, everybody, and nobody. So 4 people with those names. So there was an important job to be done, and everybody was sure that somebody would do it. Anybody could have done it, but nobody did it. Somebody got angry about that because it was everybody's job. Everybody thought anybody could do it, but nobody realized that everybody couldn't do it. It ended up that everybody blamed somebody when nobody did what anybody could have done. And that basically sums up our recommended unfunded vaccine space. Is who is responsible? Is it everybody? Is it somebody? Is it anybody? Because right now, it's nobody. So thank you so much for listening to this presentation. It highlights some of the challenges we see in vaccine delivery and recommendation. Ultimately, we need to recognize the power of the healthcare provider and support them with information with all vaccines that could benefit their patients. So again, my job here is not to tell you that the sky is falling, but to quote it more accurately as a passive optimist is that the sky will fall if we don't do anything about it. Thank you.